Good afternoon, friends. I am Dr. A.K. Vats. I'll be talking on benign paroxysmal positional vertigo, the short form of which is BPPV, and I'm going to talk on the preliminary insights. Understanding the linear and angular acceleration. These are the degrees of motion. The pitch is angular. The roll is angular acceleration. The heave is linear acceleration. Surge is linear acceleration. Yaw is angular acceleration. And sway is again linear acceleration. So the sensors of linear accelerations in our body are sacules, which sense the heave, that is in the vertical axis as you go up and down in the lift. The utricals, they sense the sway, that is side to side motion. And the surge, the anterior-posterior, as we go on a walkway on the airport, we can sense even with the closed eyes whether we are moving forward or backward. And we stand by sides, we can understand, we can know which side we are moving. So this is not the topic of today. The rotational axes of the head are as under. There are yaw, pitch, and roll. So these are three axes. The yaw axis, this is the axis where the horizontal canals sense the motion. The pitch and roll are the axes, the motion of which is sensed by the vertical semicircular canals. So the benign paroxysmal positional vertigo, it is the most frequent cause of vertigo worldwide. It is characterized by severe rotational vertigo, triggered by changes in the position of head relative to the gravity. The typical situations are lying down, getting up from lying down, bending forward, turning in the bed, and pitching the head up and down, as for example, drinking water shown in this figure. The autonomic symptoms like perspiration, nausea, vomiting are more common in horizontal canal variant of the BPPV. It's a mechanical disorder of the membranous labyrinth. It is caused by the vestibular lithiasis, which exists in two forms. The canalolithiasis, the degenerative otoconal debris, detaches from the gelatinous utricular matrix and inappropriately enters in one of the three semicircular canals. It remains free floating in the semicircular canals, namely posterior horizontal and anterior in that order of frequency. The cupulolithiasis, here the otoconal debris becomes inappropriately adherent to the cupula, making it heavy and graviceptive. The cupulolithiasis also exists in two forms, with the otoconal debris getting attached either to the canal or the utricular side of the cupula, and the acronyms for which are cup C and cup U. What is BPPV? As per the American Academy of Otolaryngology, Head, Neck and Surgery, AAOHNS, defined BPPV as a disorder of inner ear characterized by repeated attacks or episodes of positional vertigo. Pathophysiology, the mass load of the inner ear accelerometer, that is the utricle, the otoconia which normally remain embedded in the gelatinous utricular matrix, mixes with the mass load of linear accelerometer, that is the endolymph or cupula. It results in asymmetrical excitation or inhibition of the membranous labyrinth during the physiological head movements, resulting in short paroxysms of rotatory vertigo. So sensors of the angular and linear accelerations are human beings. Vestibular system consists of end organs, semicircular canals, which gauge the angular head acceleration, otolith organs, which gauge the linear head acceleration. True axonal vertigo indicates an abnormality of semicircular canals or their central connections that process the signals from the semicircular canals. The sensation of floating or tilting may be indicate otolith system disorder. So vestibular labyrinths, they are paired structures. CNS receives signals from the both right and left membranous labyrinth and collates these signals. So in the stationary head, the tonic discharges in both vestibular efferents are exactly balanced. During motion, the right and left membranous labyrinth are alternately excited and inhibited, leading to a left-right difference in the vestibular nerve activity, which is recognized as motion. This is the physiology of the semicircular canals as we move. So semicircular canals work in pair during the angular head deceleration. I mean to say, when right posterior semicircular canal depolarizes and increases its rate of firing, the left anterior semicircular canal hyperpolarizes and decreases its firing rate to the same extent, and vice versa. Likewise, when the right horizontal semicircular canal depolarizes and increases its firing rate, the left horizontal semicircular canal hyperpolarizes and decreases its firing rate to the same extent, and vice versa. So there is a symmetrical firing of the paired York muscles that maintains a state of no vertigo. This is the normal situation. Asymmetrical firing of the paired York canals in BPPV. There is inappropriate stimulation of canal after cessation of head motion. It leads to transient sudden asymmetry due to free floating otoconia in the canal, or those that are adherent to the cupula, making it graviceptive even after the cessation of head movement. So what happens? The semicircular canals are York pairs, as I had told earlier. One hyperpolarizes, the contralateral pair depolarizes. So posterior semicircular canal shares plane with the contralateral semicircular canal, and the two horizontal semicircular canals share the same plane. So what is the pathophysiology of the BPPV? At what places the mass load of the linear accelerometer can reach the result in different BPPV variants? This is the left membranous labyrinth, the posterior semicircular canal. There are 5 variants which are shown by the red dots here, and if you count cup C and cup U variants of the posterior cupular lithosis, there will be 6 variants. So the typical variant is the one which is periampulary located. The other ones will be discussed in the future lectures. Horizontal semicircular canal, the 2 variants are the horizontal semicircular cupular lithosis and the posterior long non-ampullary arm horizontal semicircular canalolithiasis. There is a temporary form which is also called the anterior short ampullary arm horizontal semicircular canalolithiasis, which also causes an apogeotropic horizontal positional nystagmus. The anterior canal variant is only one, that is the periampullary located. So in all, there are 11 variants of the monocanalicular BPPV and 3 variants of the multicanal BPPV. So 14 variants are from each side. So there are in all 28 variants from both sides. So coming back to the pathophysiology, the otoconia gets detached from the hair cells and the utricular macula and inappropriately enter one of the 3 semicircular canals. Posterior commonest, then horizontal, then anterior. Why posterior common? Because of its gravity dependent position in both upright as well as in the lying down position. So what do they do? In BPPV, after cessation of the head motion, the free floating otoconial clot within the semicircular canal, they keep on dragging the endolymph. Thus, when head motion stops, the free floating otoconial debris within the semicircular canal drag the endolymph, generate volleys of unsolicited BOR because of the inappropriate stimulation or inhibition of the canal, and resulting in left-right asymmetry of the York semicircular canal pairs, resulting in positionally triggered vertigo. The Dix-Hallpike maneuver for the vertical canals, that is the posterior and anterior semicircular canals, and the supine roll test for the horizontal semicircular canal lateralizes the side and localizes the affected canal by inducing the oculomotor patterns that needs to be examined. I mean to say the positional nystagmus. The positioning maneuvers from the semicircular canals, posterior semicircular canal Dix-Hallpike test, which elicits a upbeat ipsitorsional, the upper pole of the eye is the beat towards the involved ear, and the geotropic positional nystagmus. The anterior semicircular canal, the Dix-Hallpike or straight hat hanging test, shows a downbeat and apogeotropic variant. the torsion is often very little or even absent. The horizontal semicircular canal BPPV, the geotropic variant, is caused by the canalolithiasis of the long non-numpulary posterior arm of the horizontal semicircular canal. Supine roll test elicits horizontal and geotropic nystagmus. It is important to note that the short anterior ampullar arm canalolithiasis is an unstable variant which leads to apogeotropic horizontal positional nystagmus. However, even during the supine roll test, it sometimes transforms into the typical geotropic variant. Horizontal semicircular canal cupulolithiasis is identified or by the supine roll test, and it elicits a horizontal and apogeotropic positional nystagmus which is persistent, that is lasts for more than a minute. So BPPV subtypes, 85 to 90% is posterior canal, 10% is horizontal canal, and less than 1% is anterior canal. So your 80 to 90% work is done if you know the posterior semicircular canal BPPV very well. Why it is common? Because of its gravity dependent position. A autocorrel debris adherent to the utricular macula, if it gets detached, it finds way most commonly into the posterior semicircular canal, and it reaches near the periampullar region, as I've shown by the animation here. What are the Ewald's law? These are very important. Julius Ewald, in the 18th century, he made some experiments in the pigeons and framed the laws that bear his name. In 1892, he cannulated each of the three semicircular canals of the pigeons and applied positive and negative pressures to observe the intensity and direction of the generated nystagmus. The two main outcomes of his research were as under: number one, the generated nystagmus is always directed parallel to the plane of the stimulated canal. That is the Ewald's first law. That is actually what we do during the positional testing. That is, we try to align the horizontal, the canal to be tested in the graviceptive manner so that it is stimulated. The generated nystagmus is stronger when the endolimb moves towards the ampulla. That is, it causes the ampullopupil deflection in case of horizontal semicircular canal. That is the Ewald's second law. And away from the ampulla, that is the ampullofugal pupillar deflection in case of the vertical semicircular canals, that is the posterior and anterior. This is the Ewald's third law. So this is how it is important to know how the autocorrel debris is moving during the positional test. This is a very important diagram from the Bornstein, because what positional nystagmus we see is a reflexive saccade. The positional nystagmus is in fact created by a slow phase viewer, and the upper column shows, the upper row shows the excitatory projections of the anterior, posterior, and horizontal semicircular canal from the right ear, and the lower row shows the inhibitory projections of the three canals from the right ear. It is important to note that if we change the side of the anterior semicircular canal, it's here, the excitatory projections of the left anterior semicircular canal and the inhibitory projections of the right posterior semicircular canal, they are to the right inferior oblique and left superior rectus. Remember this here because this is important. So I have made it simple here. The excitatory projections of the right posterior semicircular canal are to this right superior oblique and left inferior rectus, generating a slow phase viewer which is downbeating and left torsional. The positional nystagmus, which is a reflexive saccade or a fast phase viewer, is therefore upbeating and right torsional in right posterior semicircular canal BPPV. The other things can be derived like this. For the anterior canal, like this. The inhibitory projections of the right anterior semicircular canal are to the right inferior rectus and left superior rectus, generating a slow phase VOR which is downbeating and right torsional. Therefore, the positional nystagmus in such cases would be upbeating and left torsional. But this variant has never been detected or is not possible. It's not possible to have otoconal debris in the non-ambulatory arm of the anterior semicircular canal because it will fall back into the utricular macula. So I am removing it from here. It is right horizontal semicircular canal. Excitatory projections are to the right medial rectus and left lateral rectus, generating a slow phase VOR during the right lateral head roll away from the lowermost right ear. Therefore, the nystagmus is geotropic, that is right in the right lateral head roll. Likewise, the inhibitory projections of the right horizontal semicircular canal are to the right lateral rectus and left medial rectus, generating a slow phase VOR which is towards the lowermost right ear in the right lateral head roll. Therefore, the nystagmus in the right lateral head roll is apogeotropic, that is left beating in the right lateral head roll. So the slow phase VOR, which is vesicular, is here, and the positional nystagmus is here. That is reflexive saccade. This is generated by the frontal eye field and superior colliculus. I again remember you here that excitatory ampulofugal in vertical canals and ambulopetal in the horizontal canals, inhibitory ambulopetal in the vertical canals and ampulofugal in the horizontal canal. So with this pathophysiology, we start the typical posterior semicircular canal BPPV. Mechanism of upbeating ipsitorsional positional nystagmus is here. During the right Dixalpike test, there is a ampulofugal cupular deflection. The excitatory projections of the right posterior semicircular canal are to the right superior oblique and left inferior rectus, generating a slow phase VOR which is downbeating and left torsional. The positional nystagmus, because it's a reflexive saccade, is therefore upbeating and right torsional in the right posterior semicircular canal typical variant, where the otoconal debris is near the periampular region and results in ampulofugal cupular deflection as shown in the middle figure during the Dix-Hallpike testing. Do we need to observe the oculomotor patterns on sitting up from the Dix-Hallpike test in posterior semicircular canal BPPV? Yes. So this is the debris which is falling back on getting up from the Dix-Hallpike position. So this causes the inhibitory ampulopetal deflection. The inhibitory projections of the right posterior semicircular canal are to the right inferior oblique and left superior rectus, generating a slow phase VOR which is upbeating and right torsional. Therefore, the reversal nystagmus is downbeating and left torsional in cases of right posterior semicircular canal BPPV typical variant. However, it is seen in only 75% of the patients. So it is important for some reasons. One reason is that in sometimes you don't see the typical upbeating ipsitorsional nystagmus during the Dix-Hallpike testing, and you see the reversal nystagmus, and you can localize and lateralize the canal as per this. I'll show you one example here. This is a gentleman came only today, positionally triggered disease spells for past 3 days. The left Dix-Hallpike shows he closes his eyes at some time, and the nystagmus is so quick that you cannot make it direction initially, whether it is downbeating or it is upbeating. As it slows down, you can make it that it is upbeating, and the upper poles of the eyes have a torsional component which is beating towards the patient's left ear. So that is left-sided posterior semicircular canal BPPV, the typical variant. However, I recorded his reversal nystagmus also, as he was made to sit up from the left Dix-Hallpike position. This is a inhibitory nystagmus and it won't be so quick. So now it starts. There is a downbeating nystagmus which has a right torsional component. According to some studies, the persons who show reversal nystagmus like this, they have a more favorable prognosis with repositioning maneuvers. This is a lady, 38-year-old, right distal pike test, shows upbeating right torsional positional nystagmus, periampulary located, the typical variant, the most common one. So what did I do with this patient? I did right apply maneuver. Position 1 from long sitting, she is positioned to the right distal pike test. Then the position 2, the head was inclined 90 degrees to the opposite contralateral side. Each position is maintained for around 1 minute. And the position 3, again 1 minute, and then she is upright. So we have done apply maneuver. After we do apply maneuver, we assess the patient 2 times, after 1 hour and at 24 hours, to look for the elimination of positional nystagmus as well as the accompanying vertigo. So post apply maneuver we did at 24 hours. Absolutely no movement, static eyes. Positional nystagmus is not elicited and patient is free of vertigo. Follow-up of BPPV patients who undergo therapeutic maneuver in our clinic. Positional retests are mandatory at short-term follow-up to look for success of this therapeutic positioning maneuver. And sometimes there is a phenomenon called canal switch, which occurs in roughly 3% of the cases. That is, the otoconal debris has gone back into the utricle, but it has not got embedded in the utricular macula. So it re-enters the other canals. Most common is the horizontal semicircular canal, because the non-ampullary arm opening is close to the opening of the posterior semicircular canal. In our center, we conduct positional retest at 1 hour and 24 hours after the therapeutic maneuver. There are at least 4 variants of the horizontal semicircular canal BPPV. The posterior long arm, that is non-ampullary arm, posterior horizontal semicircular canal lithosis, is results in geotropic nystagmus. Cupulolithosis either on the canal side or on the utricular side, as well as anterior arm horizontal semicircular canal lithosis, results in apogeotropic horizontal positional nystagmus. The horizontal semicircular canal BPPV is interesting because here the lateral head roll elicits nystagmus on both sides. Geotropic, where the quick component beats towards the lowermost ear in the lateral head roll, and apogeotropic, where the quick component beats away from the lowermost ear. This is shown by animation here. The geotropic, the quick component towards the lowermost right ear, and the slow component away from the lowermost ear. In the geotropic variant, the involved side is the one with the stronger positioning nystagmus during the supine roll test. Quick component away from the lowermost right ear. The involved side is the one with the weaker positioning nystagmus on supine roll test. 18-year-old boy, supine roll test, right lateral head roll elicits a geotropic nystagmus, quick component beating towards the lowermost right ear on right lateral head roll, as well as during the left lateral head roll, and this is significantly stronger. So as we had said earlier, it is the side that elicits the stronger geotropic horizontal position nystagmus is the side which is involved. So what did we do with this patient? Buffoni maneuver, From the short sitting, the patient is positioned to the non-involved lateral recumbent for 2 minutes. After 2 minutes, the head is inclined downwards around 45 degrees. Here it is shown 90 degrees, but 45 degrees is just enough. After 2 minutes, we complete the Buffoni maneuver. That is, it's a 4-minute gap, Buffoni maneuver. And verifying supine roll test 1 hour after the Buffoni maneuver. Lateral head roll to left, no nystagmus. To the right, no nystagmus. And no vertigo. This was in 2019, and this patient never returned after that. This is how the otoconal debris, which is shown in red, moves during the Buffoni maneuver. In the right lateral recumbent, that is the non-involved side, the horizontal canal becomes vertical and it goes near the vestibule. As nose is positioned downwards around 45 degrees, it enters into the utricle, and as the patient is uprighted, the debris clears from the horizontal canal and leading to cure. Anterior semicircular canal BPPV is the rarest of all. Why? It is almost impossible in the upright positions for otoconal debris to move against gravity in the periampullar location. It can occur during the roadside accidents or in the persons who are doing yoga, especially the Shishasana. So this variant is very unlikely, is the rarest of all variants. And even if it somehow enters into the anterior semicircular canal, as the patient lies down, it will go into the non-ambulatory region of the anterior semicircular canal, and on uprighting, it will drop into the utricular. So autocorrection again is the factor which helps in making it a lowly frequent variant. So we do a straight head hanging test from the upright long sitting with this head straight ahead. The head is taken around 30 degrees below the horizon, like this. So when you do this, when you see a positional downbeat nystagmus and you are sure that it's not a central nystagmus, you complete the Jacobino maneuver right here only. I'm showing it here. Downbeat nystagmus, very little torsional component. Possibly to patient's left. So what did I do this with this patient? Not exactly this patient. This is another patient in which the left disc sulpike test. This is 11 or 12 years back. In the left disc sulpike position, after a latency shows a typical downbeating crescendo decrescendo right torsional nystagmus. So even if it's a left disc sulpike position, the torsional component is beating towards the patient's right, and therefore it is right anterior semicircular canal BPPV. In the anterior semicircular canal BPPV, the disc sulpike test to right as well as to the left as well as in the straight head hanging position can be positive, and it is the direction of the torsional component that lateralizes the side. The torsional component beats towards the side which is involved. So this is the Jacobino maneuver. In patients who are apprehensive, I use a pillow of around 4-inch thickness as a vantage point, and in this patient. पहले बेड के ऊपर बैठे ऐसे लॉन्ग सेटिंग में हाथ घुटने पे रख के बटन के पीछे 4 इंच मोटा तकिया रख के 4 इंच से कम मोटा नहीं होना चाहिए। आधे मिनट तक बैठ जाएंगे, अपना गर्दन स्ट्रेट है, ठीक है, मिड लाइन में। ये पोजीशन नंबर 1 है, आधा मिनट में कैसे करें? जब आधा मिनट पूर्ण हो जाएगा पोजीशन नंबर 1 में, तो आपको बिल्कुल गर्दन इसी स्थिति में रखते हुए सीधा का सीधा लेट जाना है, ताकि गर्दन इस तरीके से लटके, डीप हेड हैंगिंग हो। ये पोजीशन नंबर 2 है, ये भी आधा मिनट। ये जो मैंने आपको कराई थी इससे पहले एक्सरसाइज, ये उसी का वेरिएशन है। उसमें अपन क्या बेड के एज पे आपको लेटा देते हैं, ठीक है, जो कि आपके लिए प्रैक्टिकली संभव नहीं होगा। ये पोजीशन नंबर 2 खत्म हो गई। अब पोजीशन नंबर 3 में आप चेन अपने चेस्ट पे लाएंगे और आपका हेड जो है आसमान की तरफ हो जाएगा। चेन टू चेस्ट पोजीशन, हेड आसमान की तरफ। ये पोजीशन नंबर 3 है, इसके अंदर आप आधे मिनट तक रहेंगे। जब पोजीशन नंबर 3 में आधा मिनट पूरा हो जाएगा, तो अपन ऐसे ही उठेंगे और उठने के बाद फिर अपन गर्दन सीधी कर लेंगे। और ये पोजीशन नंबर 4 है, ये आधा मिनट की। So the points to remember is that an ipsilateral anterior semicircular canal BPPV and the contralateral apogeotropic posterior semicircular canal BPPV, which will be discussed at length in the coming lectures, produces identical oculomotor responses during the positional test. Response to the therapeutic maneuver over 48 hours is the only definitive way to distinguish between the two as above, as per the Califano 2014 and 2021. The excitatory projections of the left anterior semicircular canal, that is the ampulofugal cupular deflection, that a note I had made when I showed the diagram derived from Bronstein earlier in this lecture, and the inhibitory projection of the right posterior semicircular canal, that is the ampulopetal cupular deflection, they are to the same pair of muscles, that is the right inferior oblique and left superior rectus, which co-contract as per the Sherrington's and Haring's law, generating a slow phase viewer, which is upbeating and right torsional. The positional nystagmus, which is a fast phase viewer or a reflexive saccade, is therefore downbeating and left torsional, whether it is left anterior semicircular canal BPPV or apogeotropic right posterior semicircular canal BPPV. In 2021, Califano published a paper of 630 patients in his series, and he found that apogeotropic posterior semicircular canal BPPV is 6 times more common compared to the anterior semicircular canal BPPV. Therefore, I treat peripheral positional downbeat nystagmus as apogeotropic posterior semicircular canal BPPV more often than anterior semicircular canal BPPV. In general, a trick here is to complete the therapeutic Giacomino maneuver during the straight head hanging test. And if immediately on retest you don't found abolishment of the downbeat nystagmus and accompanying vertigo, take it for granted that it is not anterior semicircular canal BPPV. A single maneuver, Giacomino maneuver, should be sufficient to clear the otoconal debris near the periampular region of the anterior semicircular canal. And if it doesn't take place, take it for granted that it is not the anterior semicircular canal BPPV. The learning resources from the internet, from the NEGM group, you can find the YouTube link here. Here, Professor David Z from the John Hopkins, one of the most distinguished authorities in neurology, has given the maneuvers over the time, these manures have changed because this video was recorded by him around 18 years back. I finished my lecture here. Thank you very much.